We're actually shooting indoors today because it's been pretty rainy where we are, and I wanted to make sure I didn't have to deal with the rain for noise in addition to the regular stuff we have to deal with, like the dogs and such. Sorry, that's our current. Um, yeah, that's a YouTube channel. That's the VMV Hypoallergenics YouTube channel. So just checking that you can hear me rather, and you can see me well enough. We'll be starting right about now, basically. But welcome back to everybody. Let's see. If you could give me an inkling, if you can hear me well and see me well, if there are any problems whatsoever. All good. I'm getting feedback on Facebook that you can hear me. On YouTube, I hope you can as well. Yeah, so there, we should be able to start. Yeah. Okay, so welcome again to Skinsights Live. This is where we talk to primarily my mom, who is our founding dermatopathologist. I'm Laura, the CEO of VMV Hypoallergenics, and October 29 is World Psoriasis Day, so this is kind of perfect for our topic today, which is psoriasis, which is a big concern for a lot of people, and because it is multifactorial and has to be sort of attacked from different angles, and it can take a while for long-term clarity, and then after long-term clarity can kind of come back. We thought, we had an earlier live stream that was eczema and psoriasis together, but we figured for World Psoriasis Day in October, it might be a good idea to really focus on psoriasis. So that's what we're going to do today. For anyone looking for great resources, there's a wonderful organization called the International Federation of Psoriasis Associations, and you can find them online at ifpa-pso.com, or just Google International Federation of Psoriasis Associations and you'll find them. And they're the major mover behind World Psoriasis Day. Before we get started, if you're on YouTube, please don't forget to subscribe to our channel. Click the bell for notifications. You can customize them anyway based on how much you want to be able to receive notifications on, like all new content or specific new content. But we're trying to get a lot more content that's informative up there for you every week. So don't miss it. So subscribe. And if you're on Facebook, please follow us. And we're also on Instagram and a bunch of other places. But to me, the most important thing during these lives is please don't forget to ask your questions in the comments early on so that I can help manage them and try to get them in for my mom, and we can make sure that you get your questions answered. So psoriasis has been a cause really close to my mom's heart, and she was really early on in the embracing of the concept of needing to manage more about the person than just their psoriasis or just their skin. So she was behind, I think, one of the first support groups for psoriasis in the Philippines, where she practices primarily, although she's licensed in New York as well. And she really got into lifestyle and nutrition as important factors for the management of psoriasis. And early on, she was one of the few who was doing bath puva treatments, and she was also an early adapter of biologicals, which she'll talk about later. But because it's another inflammatory condition like acne or eczema, a lot of our products tend to get prescribed for maintenance, for adjunctive care, because it's allergen free. It helps prevent triggers for flare-ups. It keeps the barrier loved and cared for. And so, if you have psoriasis that has been sort of stubborn and you're frustrated, do ask your physician about biologicals, because some of them can be pretty miraculous in effect. They aren't cheap, but some health insurances now in some countries cover them. If not, some of the companies that make these biologicals offer financial assistance, especially now in COVID. So look that up and ask your doctor about that. And normally what a regimen of supportive preventive maintenance care at VMV for psoriasis would look like is a very, very, very gentle, allergen-free hair and body wash. And we normally recommend Essence hair and body wash for that. but also, I don't know if you can see this. Yes, okay. This is Coo and Clean Baby Wash, Mom and Baby Wash, and as the name suggests, it's really, really gentle. It's made for extremely sensitive skin, even on infants. So it's a great option, especially if your psoriasis is sort of, you know, a little bit active, let's say. And conditioner, Essence conditioner, because it's also allergen free. So those two things would be your hair and body regimen. Definitely no hard soaps, which can tend to be denaturing to the skin and drying, period. And then you would follow it with a facial cleanser. We have a nice one in Super Skin for Moisture Rich, the Moisture Rich Cleansing Cream. But this is a great option too because it's anti-inflammatory. It's the Red Better Cleansing Cream, which is awesome. It's actually quite cooling. It's got anti-inflammatories in addition to being allergen free, and it's non-drying at all. It's really, really gentle and lovely. And then you'd follow it with a good barrier repair moisturizer. We've got several options, but the two actually that we really like to recommend are either Mommy Coddling All Over Lotion or the Essence Hand and Body Soother. Both also have anti-inflammatories. Both contain virgin coconut oil and monolaurin. So yay for that. And you all know by now how much we believe in coconut oil and monolaurin, just because on the basis of the clinical studies they're really quite phenomenal. Speaking of which, after that daily moisturizer, you would follow with Oils Well Nurturing Do It Oil, or our can you see that? Should I move closer? Is that too close? Or our Know It Oil, which is our clinically published virgin coconut oil. It's actually the same oil in both things, but Oils Well has pure monolaurin added to it. So you have an extra sort of anti-inflammatory, antimicrobial in there, which is important for skin with barrier defect, because when you have cracks in the skin, it can become opportunistic, or rather it can be welcoming for opportunistic microbes that are not good, and then you have to deal with a secondary infection. When you have spots that are sort of acting up, Boo Boo Balm is a great option to kind of get that in check. One of the key things, if you saw our live stream from 2 weeks ago, is we are seeing an increase of people who become steroid dependent, and a lot of the people we see that happening in is people with psoriasis, because it's pretty dramatic when you put the steroid on, how clear, amazing the relief is, how quickly. The problem is over time, and steroids are phenomenal, important drugs. So if you are prescribed steroids, you gotta take them. But usually, topical steroids, usually it's for up to 2 weeks. A lot of people now seem to tend to use them far more often, daily, almost like a daily moisturizing cream. And it's a real problem because, among other things, it results in tachyphylaxis. This is the word of the day the other day. And which is a decreasing efficacy of the drug. So you actually need more and more of it to get the same relief. And this strengthens the steroid dependency, which can lead to a lot more problems, from thinning of the skin to steroid acne, stretch marks, secondary infections, contact dermatitis, and a rebound effect, which can be really severe. So we've had to assist a lot of patients in the hospital actually trying to get off of steroids. So unless your doctor has prescribed a steroid, if you're seeing a flare-up, Big Brave Boo Boo Balm is kind of a good staple to have around the house. And if it needs a little more, you're also seeing redness, use the Red Better Calm the Heck Down Balm. We tend to use both together if we're dealing with sort of a really angry flare. Another thing that my mom really, really tends to double down on with psoriasis is health and nutrition, which she'll get into later. So she does tend to prescribe monolaurin pellets, which are pure monolaurin that are waxy pellets that you take. And she even, and this is not a product we make, but this is the one I use because it's a quick dissolve. She tends to prescribe actually melatonin, right? This is, I think, a 5 mg melatonin. The key thing here is that it's quick dissolve. I don't know this brand. We don't necessarily partner with them or anything, but melatonin is a great anti-inflammatory produced naturally by our brains. And it's one of those supplements, one of the few that is processed well into a supplement, so you know you're actually getting the thing. Plus, it's a wonderful anti-inflammatory and antioxidant. It's non-addictive. It does help you sleep. It's great to take to normalize your circadian rhythms. So those are some of the things that we tend to recommend for psoriasis. And you can shop all of our products, not the melatonin, obviously, that's just my share, at vmvhypoallergenics.com globally, or in the Philippines at vmvhypoallergenics.ph. And right now in the United States, if you shop 5 of our virgin coconut oils in this handy size, and I keep saying I love this size, and so do the frontliners we work with, because they can keep it in their pockets and use it regularly throughout the day. And this is now on 30% off. And the equivalent in volume is actually more than our full-sized coconut oil, and you get the 30% off, which is pretty awesome. And in the Philippines, we have a really cool treat. It's called a skin calming bundle, because 2020, we all need calming, including our skin. And it comes in this cute, I get my dew pouch, and it's got like 5 products in it, if I'm not mistaken. It's got the Clark Wash Mini, it's got the Essence Conditioner Mini, so 2 of these, and then the Red Better Cleanser and Oils Well Mini. So yeah, it's quite a bit of products in this thing, which is cool. And that's on vmvhypoallergenics.ph. And then both in the Philippines and in the United States, we're giving, I think all our makeup removers are 10% off now, which is cool. I mean, Halloween's not going to be a big thing this year, I think, but they're still nice. As a pre-cleanse, especially, you don't want to over-cleanse your face. We're starting to get into cooler months in the United States in some areas, and using a makeup remover first can be great for lessening the amount of cleansing that you need after. And we have 2. We have one that is with our virgin coconut oil, and we have another that's oil-free. So that's also happening. Again, in the Philippines, we have 2 clinical studies ongoing. The chronic spontaneous urticaria is closed, but we're still looking for subjects for hidradenitis suppurativa, which is recurrent boils in the skin folds of the underarm, the neck, the groin, and it's a wonderful study. And if you have psoriasis and you're in the Philippines, we do offer a really, really comprehensive care facility, from bath puva to a really amazing nursing care, sort of like immersion. If you imagine marinating in virgin coconut oil and monolaurin and being, really soothed and massaged, it's kind of divine. And also biologicals, of course, and patch testing and dermatopathological services. Drop us a DM and we can help make that happen. And if you'd like a teleconsultation with my mother or any of the doctors and nutritionists that we work with, also drop us a private message. And for everyone everywhere, remember that if you've had a patch test, you can share your results with us, and we can customize recommendations for you based on your particular allergens. So there's a lot of management, but I'm going to call the expert in because she knows far better than I about all this stuff. This is my mom. There you go. Have a seat. Hi, Mom. So Dr. Germaine Beralio Rowell, I was sharing with everyone, Mom, parang growing up, it was such a cause close to your heart, and you were, early on a proponent for the support groups and all these things. And I've seen her, she's published everywhere, she speaks everywhere on psoriasis and more. And I find her refreshingly one of the dermatopathologists that really links caring for the entire person, not just the psoriasis, right? And seeing the interconnectedness of all the different systems. So, say hi.
Thank you for the introduction, sweetie.
I try to get it right.
This is my favorite older daughter.
I'm the only one. Okay. So, starting with the basics, what is psoriasis? What are the different types of psoriasis? What does it look like, and where does it tend to occur on the body? So could you just give us like an overview? What is psoriasis?
So description-wise, psoriasis is red, thick, scaly, itchy a little bit or more, and it occurs in various parts of the body. It can be just in the nail, could be in the genitals, the hidden areas, or could be
I didn't know that. It can be the genital areas also.
It's terrible when it's there. To the patient.
Yeah.
The palms, the soles. It has a very different kind of appearance for many people. But the main thing about psoriasis is that it is red, thick, and scaly as a rule, and it can produce manifestations that's also in the body. But we'll get into that later.
I have to tell you, Joseph de Guzman is watching and saying hello. For those who don't know, Joseph de Guzman is sort of a rock star.
He is a rock
in
star.
the global
He's a rock star.
psoriasis community. He at one point headed SORFIL, which is the psoriasis organization
Still
of the
the head.
Philippines. Excuse me, still the head, probably forever, and very active in the World Psoriasis Day and sort of several global organizations for psoriasis. Such a wonderful advocate. So, hi, Joseph. Yay.
Hi, Joseph.
Okay, sorry. So back to what is psoriasis, right?
So, the thing is that there are therefore, based upon the way it looks, because we're talking about the looks first, it is either plaque. The most common type are anything more than 3 centimeter is a plaque.
Sorry, so she's talking about lesions that are visible,
Mhm.
right? So plaques
Right.
are more clearly defined, almost like if you were looking at a map, they would be like islands or
Mhm.
like continents.
Right.
They're clearly defined lesions that can look scaly,
Red and
thick and raised, right?
Right.
Because they look like scales that are thick.
Right.
That's a plaque.
Right.
It's clearly identified.
So that's the plaque psoriasis, and it can occur in any part of the body.
Mhm.
Okay. The next one that is common, especially in our part of the world, which has lots of infectious diseases usually as a background, is guttate psoriasis, which traditionally is present mainly in children or recognized mainly in children. But in my part of the world, I see a lot of guttate psoriasis among the adults.
How do you spell that?
Guttate,
There you go.
okay? Raindrops or teardrops is what guttate drops.
Really?
Yeah.
Okay,
They-
so we have plaques that are continents and we have
And there's small
teardrops
little
that are
drops.
guttate.
Okay. And then there's the one called pustular psoriasis.
Mm.
This is really one of the worst kinds because it's associated with fever,
Yeah.
systemic symptoms. And then there's what we call erythrodermic, which is what I often deal with. Erythrodermic means more than 75% of the body has become red. And sometimes you don't see the thick scaly things anymore because they're just brilliantly red all over.
Guys, think about that. 75% of the body.
body is
That's a
involved.
lot.
Right. Then, if I may go further, therefore, so that's how you recognize psoriasis, and it usually lasts. It stays for a long, long time. So that, as Joseph will tell us, one of the most important things we have to deal with in psoriasis, as a person from childhood, if it occurs there, or to adults, or to teenagers who are developing, or to people working, one of the main things I deal with and I'm very aware of is the quality of life of people with psoriasis.
Yeah.
Depression, suicidal tendencies, ideations, so I'm always talking with patients and chatting with them and making them my friends, making them realize I'm there for them. So that's part of it.
I actually, if I can add on to that, I actually think that's one of the things that over the years has changed a little bit in psoriasis, in that thanks to the hard work of advocates like Joseph, like the International Federation of Psoriasis Associations, like SORFIL, there's so much more information about psoriasis that's out there, which this is anecdotal, of course, just my impression, but I think helps people with psoriasis and people who have friends with psoriasis understand the condition better, because before people thought it was contagious. People thought, oh my gosh, it looks like leprosy.
Right.
Like there was such
It was described as leprosy in the olden times.
there was an ick factor, right? And I remember clearly one of the themes for one of the years for World Psoriasis Day was like, hug me.
Yes.
To try to get over
Shirt
this.
said, hug me.
Right, to get over this fear, this really misinformation that it is contagious or something disgusting or bad. It really isn't, right? But she's right in that there are wonderful studies now that have been tracking depression, anxiety, suicidal ideations in people with psoriasis. I really hope that's on the decrease. Of course, it's COVID, so some of that's on the increase, but it is an important factor in the total management, right?
Yes. What else can I say that's external?
What are the other risks associated with psoriasis? Like, I know it has comorbidities.
Okay.
Right?
Psoriasis is genetically controlled in a sense, or initiated. But although there are some people who, when they come to me, they say, but nobody else in their family has psoriasis. Still, there's a number of them who do give a history of psoriasis in the family. And it occurs, by the way, there's the young version below the age of 40, and above the age of 40, that's called adult psoriasis.
That actually addresses Penny Lane's question. She had a question about what about someone getting psoriasis in old age, like above 70, and they never had it when they were younger, and is it curable?
It is still psoriasis. In cases like that, and this is, my own version of treating patients with psoriasis, is that when it is an older person, I always look for drugs, especially for hypertension, because several of the drugs can be, or for depression, there's one drug called lithium that is what we worry about because they can induce psoriasis. So getting into therefore what
they can
I call
induce psoriasis.
They can, yes.
They can trigger the
development of what we call psoriasiform drug eruption.
There you go.
And in people who have some genes for it will probably go on to true psoriasis and not just secondary to the drug itself, because even after you withdraw the drug, the lesions persist. Which reminds me that the more important thing for us to remember is that although the genes are important, the study on genomes, for instance, that identified the 25,000 genes, was a very important discovery. But shortly after that came the exposome project. And why? Because people began to realize that the genes may be that important, and they are truly very, very important. But the exposomes that affect those genes and bring out the psoriasis, bring out the various diseases associated with genes, those are as much as 75 to 85% important, or about
what
that
are
number.
exposomes?
Okay, exposomes are the environmental factors that actually interact with the genetic,
Right.
so that then you develop the skin disease, in our case, for dermatologists, or other disease in the body, including the GI tract, the arthritis, and all of that.
So you can actually have diabetes in the family, have it in your genes,
Yes,
but you don't necessarily have to develop diabetes.
that's right.
There are things that you can control in your life, like you can be extremely careful about your blood
Right.
sugar, what you eat,
Yes.
your health, and all of that, and prevent getting it at all.
That's right.
And there are newer studies on genetics, and we're veering a little bit here, but epigenetics to me is fascinating because it shows that behavior can turn on or off certain proteins
Right.
that can then affect generations moving forward,
Yes.
regardless of what genes are there. So it's all really fascinating. Point being for this, psoriasis, yes, can be genetic,
Yes.
but just because it's in your genes doesn't mean you're
You have to give up.
necessarily going to get it.
Yes.
You can prevent it.
You can, in
And
fact.
if you don't have it in your genes, that also doesn't mean that you cannot get it, because it can be triggered by certain drugs, etc., etc.
Right.
So, in terms of other comorbidities, like I know if you have psoriasis, a concern is arthritis, diabetes,
Cardiovascular disease.
cardiovascular disease,
Depression.
Right.
Yeah.
So it's not just a skin thing. It
Right.
really is a systemic, inflammatory condition with comorbidities, and it does require appropriate management, meaning not just the skin.
Yes, so let's go now to the fact that so that was the visibility of the skin lesions and psoriasis. But what has been coming out in so much of our literature in the past at least 15 years or more is the fact that psoriasis is, in fact, an inflammation. It's an inflammatory disease, most obvious in the skin because this is what is so visible to us, but equally existing inside the body, driven by the same factors
Right.
that makes that epidermis thick, red, and scaly, but also affect various organ systems in the body, so that, as mentioned, you can have diabetes develop, cardiovascular disease is the most common, hypertension, Crohn's disease, gastrointestinal inflammation as well. So these are the things that can actually develop. Even Alzheimer's has been related to psoriasis as well, or at least some kinds of dementia. But the thing is that it is no longer considered and should not be looked at anymore as just a skin disease. It is, in fact, a generalized systemic disease. We should be aware of that because the newest treatments, if I may go now to
Yes,
treatments,
please,
I'm so excited about it. Your new treatments to share with you guys, because in the old days, let me first get down to the percentage of people who are affected by psoriasis. It's more common, it seems, or has always been traditionally said to be more common in temperate countries and among people with white skin. The truth is, in our country, for instance, in the Philippines, where I practice most of the time when I'm not going back to the U.S., in the Philippines, initially a group of us in the 70s, published a paper which said it's not common. It's only about 0.6% of the population. And this was based upon a Philippine study all over the country. 0.6 only. Well, over time, and with the help of people like Joseph de Guzman here, our psoriasis expert support group,
He's getting a lot,
with the help,
a lot
with the
of
help
love.
of Joseph and all, and doing caravans all over the country and getting them disability cards is really amazing. But anyway, going back to that, we have found out that first it wasn't just 0.6, maybe it's 1%. Then more people review their data and all that, and it went up to 1.5. Now it's about 2%, equaling the number that normally is reported in the United States. So it may be that the countries that we were before were very poor, that we didn't recognize psoriasis, or they just treated themselves with herbs and whatever there, or nothing at all. And of course, therefore, they never got to the doctor. They never got identified to have psoriasis. So as far as I'm concerned, psoriasis is really pretty common as well in countries that used to be called third world countries, but are now called developing countries by the WHO and all. And remember, this is about 60% of the world's population. So it's pretty common.
Yeah.
Right. So
In terms of treatment.
in terms of treatment now, the beauty about the
Actually,
treatment...
before we get to treatment, what I'm really what I'd like to clarify, I guess, for people who are watching and may not be familiar with it, is psoriasis, we hear, when people contact us, tends to be confused with other skin conditions. Or other skin conditions, or let's say a psoriasis will not be called a psoriasis because, it's just, I don't know, an atopic dermatitis.
Or
right?
eczema.
Or eczema or contact dermatitis.
Right.
Why are they are they at all related? Why is it that so much confusion and even misdiagnosis abounds?
Oh, it abounds. Misdiagnosis. I'm kind of a third layer referral doctor for psoriasis in my country, because I'm old enough to take care of the more serious, really bad cases that need
The
to be
last
hospitalized
resort.
already. I'm sure there are several out there also among us dermatologists, but we really get to see very severe cases that very often has been misdiagnosed. It turns out that they were using steroids, topically for instance, and by applying it on their skin, whether it was eczema or whatever, they become erythrodermic from it. They become red all over, and they become misdiagnosed as psoriasis, when actually what the patient was treating was a form of eczema like atopic dermatitis, which also has red and sometimes thick and often scaly spots, and therefore becomes misdiagnosed. So what you need to do is, it's like peeling and peeling the layers. Not the skin.
Investigating the
Peeling
causes,
the understanding to
the
what
symptoms,
is this really? Is this eczema or is this psoriasis? Turns out many of them turns out to be something else, and that's psoriasis. Some of them could be just a drug eruption.
She had a case where it was a young boy and he was being treated for psoriasis, and she kept looking at him and going, I just don't think it is. And I think she did a biopsy on him and then did blood work, and it turned out to be syphilis. So I'm just saying,
Yes.
it can be confused.
Yes.
And it's probably a good idea, especially if it's not responding to anything.
Right.
It's probably a good idea
good
to
signal.
dig deeper.
Initially, it will get better. Excuse me, love.
Yeah.
Initially,
Sure.
it'll get better because it is red, thick, and scaly, and that's from inflammation. So, a good anti-inflammatory, put the clobetasol or some potent steroid there, and so therefore the redness, thickness, and scaling improves. But then it stops there, and it continues. When things like that happen, I always say maybe it isn't. Maybe we really have to look into this more closely and find out if, in fact, the patient has contact dermatitis. Very common as well. That it is,
So she'll tend to do several diagnostic tests, right? So she'll even do blood tests. She'll do a skin biopsy. She'll do, it depends. If there are some sores maybe that look infected, she'll do a culture, and she'll do like a sensitivity a smear and do a culture and sensitivity test. And she'll often even do blood tests for her psoriasis patients to look at inflammatory markers in the system.
Very recently, I gave a talk about the unusual appearance of fungus infection in psoriasis. Normally, we doctors recognize fungus as appearing as either tinea corporis or those circular things with an advancing border with a scale.
I love how you talk like,
Right.
yeah, you know, the tinea corporis with the thing, the
But
border.
the more common clinical appearance of fungus. Well, the study I reported, series of them, last week was the fact that there are, if you really look very closely, I show the audience, you will notice that besides those dark those psoriasis which are very well demarcated, you will see there are tiny little dot-like. They're dot-like and uniform, but dot-like little things surrounding it or beyond. So I thought maybe it's really new guttate psoriasis, you know? And for a long time, I ignored it, except it was just there. And so finally I did a scraping. Bingo. There was fungus in it.
Right.
Another person, I scraped something that looked like rosacea, turned out, no, it was on the body. I scraped that one on the trunk, and it turned out it had Demodex, another kind of
Mite.
It's
It's
a mite
microbe,
in the
yeah.
skin that is, it's really a normal microbiota ingredient of
Yeah.
our skin.
We get
But
along.
when steroids are constantly applied on the skin, the barrier is defective. There's a change in the
Microbiome.
microbes of
And
the
they
skin,
can tend
right?
to
And especially
get
because
off
they're given
balance.
antibiotics and all sorts of other things, then it kills all of the bacteria, or they get exposed to all of that chlorine that
And
everybody's
it
using
really
in the environment.
imbalances our microbiota.
So it imbalances everything, and this is why this fungus comes out. And they come out, especially for those who are sweating a lot, they come out like sweat
Right.
prickles
But-
or whatever.
Point being then, psoriasis can be quite complex to diagnose to begin with.
Go to a dermatologist who must diagnose it properly for you.
Exactly. And also note that, if I'm not mistaken, psoriasis can coexist with contact dermatitis,
Absolutely.
atopic dermatitis.
Right.
It can coexist with other things. So just because you have eczema and that's, clear, it doesn't mean you can't also develop psoriasis. Just because you have psoriasis doesn't mean that you shouldn't also check for contact dermatitis, because one of the first things she does actually with a psoriasis patient is definitely do a patch test,
Yes.
because exposure to your allergens can definitely trigger.
Can be one of the exposomes.
There you go.
Yeah.
So
There's a very nice article. I had to review this because I gave a presentation in Indonesia a couple of years ago, and I was thinking, there is contact dermatitis and psoriasis in the same patient? Because I did. I mean, I showed it in the patch test, and the biopsy and all that. And apparently, that's what's. And you find it. There's a big university in Germany. I'm really sorry, I forgot the name. University of Friedrichsburg or something like that. I apologize for not remembering.
look it up.
And it did a very thorough study showing that the cells you see that elicit contact dermatitis are called T cells, whereas the ones that elicit the contact dermatitis is also
You said contact or
Contact
T
dermatitis.
cells are
Yeah.
involved
Yes.
with contact dermatitis. In psoriasis, they are.
they are different from
Right.
the T cells that are involved in the contact dermatitis generation, pathogenesis. So I was thinking they can't be, because then that will confuse the bloody cells. Well, it isn't, as proven by this group of doctors in Germany. And it was so well presented that therefore I used that as a background to what I showed them of a couple of patients who, in fact, after I had cleared them up sufficiently and there was no more steroid in their body or on the skin, showed that patch tests were positive and it was really psoriasis as well. And by treating both, as for psoriasis and for contact dermatitis, removal of the things they were using or applying, patient improved. Until now, she's 100% clear.
Which
Yeah.
brings me to 100% clear.
Yes.
Can psoriasis be cured, or is it like herpes? It just needs to be managed for a lifetime.
Yes.
But can you get to 100% clarity?
Yes.
And how? This is the treatments.
Very much so with the new, It's really amazing.
Yeah.
You should love us dermatologists all over the world. Europe, America, Japan, the Southeast Asian countries as well as the South American. We are doing lots and lots and lots and lots of studies on psoriasis, so that so much about psoriasis is now well known, and this has led us to go into the genetics and the molecules that are involved.
Wait,
And what
I think we
actually-
might be disconnected.
Ooh, okay.
Give us a sec. We're gonna
Okay.
double check. But I seem disconnected. No, I think we might still be okay in Facebook. So sorry. Please go
Okay.
ahead. Let me interrupt.
So
you.
that these are now been identified, including those little tiny chemicals called cytokines and chemokines. They're in the skin, and they're the ones that then tell the top layer of the skin, the keratinocyte, to react, and then they produce those what we call inflammation markers. And what is current with the studies that have been done is that there are now what we call targeted treatments for psoriasis, targeted against IL-17 producing cytokines, against
I think
23.
we might have lost people.
Ah,
We're
okay.
talking about biological.
We will not go a little.
No, we're talking about biological.
Anyway, the current treatment
Okay.
now that really works very much is targeted. But we as dermatologists see moderate to severe cases. Mind you, 85% of psoriasis patients are just mild, and they are treated very easily and then go away, hopefully. But the ones that we really get to see are the 15 to 20% of severe psoriatics, and this is what we're talking about, where we need targeted treatments, and these targeted treatments are amazing. They really clear the skin of the psoriasis patient. So the next question then is, can you withhold it? Can you maintain that
Clarity.
that clarity of the skin? Well, there are new studies again now. This is very nice because I used to practice that, and I'll tell you why. Of treating psoriasis early, rather than waiting until they're generalized and all over, rather than waiting for it to become very severe. In the Philippines, where I practice, many people cannot afford the biologics. It is too much beyond their reach unless they're part of a study for international company. So what I've done for people like this is I convince them to try to get at least a couple of injections, and by giving it, timing it well, giving it, and then they clear up, and I tell them, like I told you earlier, I'm friends with my patients. They have my email, they have my telephone number. Said, just text to me when you first get the second, third, fourth, fifth, sixth lesion, about less than a palm of your hand. When you do that, we're going to treat you again.
Okay, so let me.
That's what I did before, until the paper started to come out saying, yes, indeed, earlier treatment of the psoriasis with the biologic actually helps and works better.
Okay,
Well,
so
this is still.
I'm gonna try to break this down and summarize because there's a lot there, right? So first, can psoriasis be cured?
No,
It's management.
yes, it's managed.
Okay.
But I never say to patients anymore that this is going to be all your life or lifelong. That's so
It's
cruel
management.
to tell a patient that.
Okay.
That,
But the nice thing, though, is the lifetime of management is far more successful than it ever has been in history.
Correct. Yeah.
So that when we talk about a lifetime of management, it really could mean the majority of your life henceforth being 100% or close to 100% clear. And that can happen with targeted but also systematic care,
Yeah.
right? So
Like I told you earlier, sorry, Lau,
please,
I
please,
really have
please.
to
This is her thing, clearly.
What I told you earlier was that here's the genomes and there's the exposomes, which is, let's say, 65, 75, 85%.
Remember, exposomes are the
that
external
affect
factors,
the genes, right? So those environmental factors, which mean external, what you control, and internal, what you bring in. So it becomes, for my patients, I make it sure that it becomes a lifestyle for
Right.
them. To have an anti-inflammatory lifestyle, which really means sleep.
Okay, wait. So let's back up. Again, so it cannot be, quote, cured in that it is a lifetime of management, but management now is better than it's ever been. You can be 100% or close to 100% clear for many, many, many years. All of this starts with a proper diagnosis.
Right.
So first you really have to go to a specialist to make sure the diagnosis is correct. And even mega experts might misdiagnose just because it's so complex, especially if you've been overusing steroids, especially if you also have contact derm and all these other things. So it starts with a correct diagnosis. Expect things like a patch test for sure, possibly a biopsy, possibly some blood work, certainly a clinical evaluation and taking your history,
Cultures.
maybe cultures, to examine really what's going on. So that's number one. Once you get that diagnosis, in my opinion, no good doctor will just give you a drug like a biological. They'll still give you a lifestyle of a solution to follow, right? The prescription isn't just an injection, it's everything around it. So it might be an injection, which is a biological, which is what she was talking about, these cytokines. They're very complex, so I really won't get into it here. But you can ask us if you really want to know, and she will get into it. And she'll talk about the L1 versus the all these receptors. They're amazing. So biologicals are these very expensive drugs that you either self-administer or have to be administered by your nurse. I was on a biological for my auto-inflammatory condition, and it's an injection that I had to do on my belly every week. So if you're given a biological, they're very expensive, but as I mentioned very early in the talk, some countries now will cover biologicals in health insurance, and some of the drug manufacturers have financial aid, especially now in COVID, so it's definitely worth asking. The second thing that you're going to be told is, besides the biologicals, you might also be given your patch test results so that you can practice prevention. You really avoid any contact with your particular allergens. And then you might get a specific prescription for lifestyle, sleep, possibly going to support group or seeking therapy if you need it, or feel icky or just not well, and diet, right?
Diet's very important.
And possibly blood tests. I mean, if you might have some inflammatory markers in your blood that can be good early signs of, okay, it looks like it's starting up again, right? And what she mentioned earlier is like, I think pretty much every health condition you can think of, the earlier the intervention, the better.
Yes.
So if you notice already these things early on, already talk to your dermatologist and get that looked at.
Work with your doctor.
Definitely. So someone actually asked here, Siege Pass, does diet affect inflammation due to psoriasis? And if so, what diet should someone with psoriasis follow?
Okay.
I'm so glad you asked. She did a great study. It's really awesome.
I have a study that is called anti-inflammatory diet. Diets are interesting as far as we doctors are concerned, at least we dermatologists, and this particular dermatologist. For many years we were told that it had really nothing to do with psoriasis. We could eat anything, or even acne before. But the fact is that over the years it's now been discovered, number one, that psoriasis is an inflammatory disease. Being inflammatory, therefore, what do you use as a diet which is anti-inflammatory? All right? So what I did was get two oils to compare them and see if in the diet that they were eating, what we did was very controlled. We got the patients we gave them a lecture all about what we're talking about, lifestyle and all of that, and told them how to avoid this and all that. If they needed this and that, doctor will take care of it. And then we said, okay, blinded, one group only were given one particular oil, and the other group one particular oil, and it was blinded.
And then otherwise the exact same
it was
food.
actually just partially blinded because we could smell the smell of one and the other didn't have any smell. But that's what you call a single blind study, but with the investigator blinded as to what they were using. To make it even more controlled, we actually gave ingredients for the diet for 1 week, so that everybody had the fish that should be organic, should be very fresh and all, and oily, so that you had lots of omega-3.
And strict instructions.
Right, strict instructions. The chicken and a little bit of red meat. I don't think we gave red meat. There was just, but we gave them white chicken that was really organic, as well as organic
Lots
eggs
of fruits and vegetables.
So we gave
lots
of fruits and vegetables, and we gave that to everybody, so that there wouldn't be any, about one being different from the other. And then they would come every week examined them. We did a skin biopsy at the beginning and a skin biopsy at the end. And then those two biopsies, the beginning and the end of the 1 month that they were on this particular two oils, we then sent to Rockefeller University in New York, where they cut them into and gave us the results. I can talk about this now because we actually had this, presented this as a poster at the World Congress June last year. And it showed differences in the histochemistry, histopathology rather.
Histopathology, word of the day, folks.
Of the skin, of the lesions.
Histopathology is what?
We're still waiting for the final.
Histopathology is what?
It's examination of the skin.
Cells, right?
Right. Okay. Right. So we're just waiting for the final decision of the university we had sent it to for the RNA sequencing. So we're looking into genetic.
But already
results.
at the cellular level,
We
based
already
on biopsies,
we
you
already saw
saw
a big difference actually between one oil versus the other oil. So that's only with oils, But this is the way we doctors move. We do it kind of slowly because we want to get randomized clinical trials and all of that. But this one is going to be an important clinical study when it comes out. So beyond that, as far as an auto-inflammatory diet is concerned, based upon many other
anti-inflammatory diet.
Anti-inflammatory diet, a lot of vegetables.
The shortcut I always give is the Mediterranean diet. Follow the Mediterranean diet, but use coconut oil more than virgin and more than olive oil even.
Yes.
And what that really is if you look at the pyramid of a Mediterranean diet, it's primarily vegetables, and then if you have meats, it's going to be fish that are rich in omega-3, that's so important. Hummus, beans, nuts, root crops, and then
cauliflower, broccoli, green,
fruits,
red,
even
yellow
less
peppers.
than veggies. Yeah, so really veggies more, and fresh if you can do it. Juice if you want to, but ideally
closer to
juice
the table,
it
the
yourself.
better, rather than buying it in canned things.
Juicing is not a bad idea because you need so many veggies to make one little glass of juice, but it's always better to do it yourself because the stuff that's bought outside already has preservation, and you lose a lot of stuff because it's been in storage a while, etc. And then if you're going to do any kind of grains or breads or pasta, you want whole grains, wild grains, brown. So brown rice, wild rice, nutty bread. This is my mom's.
I wanted to show off my turmeric.
This is my mother's fresh organic turmeric. So we basically chop it up, boil it, strain it, but she adds her veggie juice in there, which is why it looks a bit like a swamp. But again, you get all that stuff, and if you add some of the stuff from the juicer back, you get the fiber. So that's a nice shortcut for what diet to follow. We have a question from LWG. We only have 8 minutes, folks, or so. So get your questions in. I want to make sure we answer her. From L, good morning, how to tackle the thick skin of psoriasis.
That is part of the inflammation.
Yeah.
The inflammation, all of those cytokines I was telling you about, that stimulate the keratinocytes. That's the top layer of the epidermis, it's the skin. And it stimulates them to become proliferative, is what we call it, and they proliferate.
To overproduce.
To overproduce, and so therefore they become thicker and thicker and thicker if that inflammation is not controlled.
I love the words. Yes. So basically, how to treat it is you've got to get to the cause of the psoriasis, right? So you got to either biologicals might be necessary. A patch test will certainly help to reduce those triggers that are causing those eruptions. Right?
It's a trigger. And the other thing that I'd like to add to that Mediterranean diet is that it doesn't say much about carbs, and what is now found is that the carbohydrates are really very important in inflammation as well, and so it should not be as much as we were told years ago that we should just at the bottom of the pyramid where all the breads and the pasta, remember those years? You're supposed to eat more and more. Well, it's not so much like that anymore. Should be eating more carbs that are more.
I told them now. Wild.
You did?
Yes,
Okay,
brown, etc.
There you go.
Sorry, I'm trying to make sure I get all the questions in. Are there any home remedies for psoriasis? Are there simple remedies that can be done to manage psoriasis?
If it's mild, definitely. You can use, I like coconut oil, for instance, because it's anti-inflammatory, it's a good occlusive, it's a good humectant.
My though,
but
is yeah, go ahead. You're going
but
to say it better.
if the psoriasis is more than a palm size, maybe you should already go see a doctor to
Yeah.
contain it and not become a moderate to severe case.
I
because
think
then you have a problem.
my face is also from maybe people who tend to want to be anti-vaxxers, or who tend to want to not ever take any kind of antibiotic or steroid, or, oh my God, I just really will refuse to. Everything in life is a balance, folks. Of course, you should not do a lot of antibiotics or topical steroids, but if they're necessary, they're necessary. If the psoriasis is at a point where it's quite widespread or recurrent or chronic, you might need a biological, period. The nice thing is it's not a biological every day for the rest of your life. It's really targeted, and it is so effective. So in terms of home remedies, I get nervous when people kind of get excited about things like, oh, I'll just brick mortar and pestle like grass and add some lemon and add banana and whatever. You might be allergic to some of those things. So coconut oil is always a nice kind of go-to, and if you have it as a staple in your home to cook anyway, that's always a nice thing.
Yeah.
But again, if it's chronic and recurrent, see a doctor, see a specialist.
It does it does get wild.
Remember that psoriasis is not just your skin. It can become a
Inside the
wildfire,
body.
and really other things can happen. You do have arthritis risk, you have diabetes risk, cardiovascular, Crohn's. There's a lot of stuff, so don't take it lightly.
The newest study have shown basically that by treating it early, you can actually reverse the tendency for these inflammatory disease to become rampant inside the body. That's been shown already in many
Exactly.
studies.
Okay, another question from Arlene, one of your avid followers. Yay! Hi, Arlene. I had contact dermatitis due to hair dye. I'm good now. Can I use organic hair color instead? Well,
Well, what do you
She has
think
something to say.
organic color is if they're really plant-based? Like henna. People will say, but I have henna here and it's natural. I said, yeah, but what's the color of your henna dye? Well, I can get it in different colors. I said, what do you think those colors are added to the natural color of henna, which is red? They add a black dye, or they add a brown dye, or they add a red dye.
yeah.
And it's the dye that you're allergic to. So be sure that
Just be sure to
what
look
they
at the
call organic
ingredients.
is truly
Yeah.
organic. Again, message of the day again, repeated all the time.
Look at the
Read
labels.
the labels in
And
the
we
back.
can help read the labels, but unfortunately, we've been trying to develop a hair dye for decades. It's really hard.
It's
And
tough.
it's so hard. And the reason is this. There are many options for less allergenic colorants.
Sorry.
For a while it was carmine, but actually that has become an allergen as well. Azo dyes are definitely allergens. Anything that's meant to stay on the skin or hair that's really meant to bind well, that's probably a dye. A lot of the less allergenic ones tend to be iron oxide pigments. Those don't stay well. They don't.
They wash.
So yeah, they wash off. So if you have a temporary dye that is made of an organic iron oxide dye, you're probably good to go. Just don't sweat. And don't go to bed with wet hair because it will wash off. So the temporary, sort of just for the day kind of dyes, yeah, you might find some that are iron oxides, but almost always, if you have a long-lasting hair dye, especially if it's black, chances are it's got that PPD in there that is a top allergen.
And remember, if you're allergic, in fact, to dye in your hair, similar dyes, very close to, that dye is the dispersed blue dyes,
Yeah.
dispersed orange dyes, that they are used to dye denims also.
Yeah.
And many psoriasis patients that I get to see, I'll see their psoriasis much worse on the legs than on the rest of the body, which can just be plaques here and there, but more, and then it's more prominent symmetrically on the knees, goes all the way down to the ankles, and at the ankles, because the denims nowadays are meant to just hug the skin, and then they stop at the ankle. Then you look at the foot is 100% clear, but it stops right there.
Okay, we're
That is
actually-
a good signal for
we're
me
out
that
of
this
time,
person
but
might
I'm
be
going to-
dye allergic.
But I'm going to just keep her a little longer because it's such an important topic and we're getting a lot of questions in, and I don't have the heart to not answer psoriasis questions. So, sorry, one more thing, Arlene. get a patch test, because you might, just in case you're not actually allergic to the dye, but maybe allergic to formaldehyde or other
Exactly.
things that are in there.
Right.
That'll help guide you better. So Jan Marie is asking, I have scalp psoriasis. Does coconut oil help? All of
Absolutely.
my scalp is already covered with thick flakes. The prescribed oil is starting to not be effective.
Right.
Coconut oil can help, but thick flakes, again, you might already need a biological. So this is, again, the kind of thing you
Depends.
should really work, right, but you should really work with your doctor to see if the oil that is prescribed is already not becoming effective. Have you had a patch test? Are there possibly other things that you're using that are causing that? Like, are you using a shampoo with fragrance or amidoamines, like cocamidopropyl, betaine? She's proud. Or are you using mousses or gels with, wet acrylates? Because acrylates tend to be a problem, especially if they're wet. When they're dry, not so much. But there might be other things at play that are actually causing that. So I would go back to your doctor and say, can we investigate deeper? Maybe I can get a patch test.
What part of the hair dye I'm using am I really, really allergic to?
No, this is a different person already.
Okay.
Yes, this is someone who has scalp psoriasis. And she's saying the flakes are very thick already.
Okay.
Right. So you might want to look into more
Right.
accurate preventive care,
Associated.
and maybe a biological will be needed. You don't quite know yet, right?
Supposedly, there are certain areas of the body beyond 10%. This is the traditional. Beyond 10%, you can treat already with the biological, because that's already classified as moderate to severe. But there are certain areas of the body that, when they're involved, we already consider that as, even though they're small areas like the genitals, the palms, the soles, actually for me the scalp as well, when it really becomes bad. Those to me already makes it a severe case, moderate to severe case, and should be treated properly cared for by your doctor, and not with you just going to the store and buying another shampoo and thinking this is going to work, or maybe that antifungal, maybe that French one, or have somebody really look into it and find out what's the best treatment for you.
And we can help you, again, if you have those allergens, we can totally help, steer you, because some of the things get confusing. We have a great question from PG on YouTube. How can we remedy discoloration from eczema? I know we're talking about psoriasis, but aren't they similar? They're inflammatory, so yeah, close. I'm black and my arms and face are 10 times darker now. So that's, it happens. Post-inflammatory hyperpigmentation, especially for black and brown skin types. Even pale brown people like me, hyperpigmentation is definitely something that we tend towards, much more so than very, very pale skins, white skin. For white skin, maybe the bigger issue might be skin cancer, although brown and black skin can also get skin cancer. You can see the redness a lot more. But for brown and black skin types, hyperpigmentation is really up there. And certainly post-inflammatory hyperpigmentation.
The good news for people for that particular question is that after the psoriasis studies were becoming really very good in their findings, biologics are also now being used for eczema, atopic dermatitis, and so therefore you'll have to go to ask your doctor if it's really bothering you, the discoloration, because again, quality of life, people, it's just color, right? But I know how bad it can feel for the person who has that problem. The post-inflammatory hyperpigmentation you're getting might be from the disease itself, but it can also from what you're applying on the skin. And so therefore you have to control that inflammation quickly so that you don't get the post-inflammation pigmentation as badly, and you don't get so dark,
So two things that I found with hyperpigmentation, especially related to inflammatory conditions from a lot of her patients and the studies we've read and how we formulate things, it really is getting at the cause. We gotta find out what is the cause. So for example, I have worse hyperpigmentation on the left side of my face, and that's because where I work next to a window. When I sit in a car, I tend to sit on the left side. So this is where the hyperpigmentation tends to be more pronounced, right? One of the first things she'll really do when she sees a patient with hyperpigmentation that's more generalized across the face and body is do a real mapping. She will have the patient disrobe and do like a really careful mapping of the patterns of the darkening all over the body, because it's hardly ever going to be a very generalized, perfectly even change from head to tips of your fingers, unless maybe it's some other disease in the blood, for example, in the system. It usually will have a pattern. For people who have underwear, was it clothing contact dermatitis, it'll be under the bra, sort of where the sleeves are, in the groin where the underwear is, maybe around the belt buckle, these elastics in our underwear. If that's the case, it might be the material. You might have clothing contact dermatitis, and you might need a patch test to help you determine.
I recently saw a man who he complained precisely about those areas being, why am I always itching there? Why is my psoriasis always appearing there? There's your answer.
Right. So it's a good idea to go to specialists who can really map what is the pattern of the hyperpigmentation. Is this because of clothing that you're wearing, in which case they might do a patch test with an expanded tray with textile-related allergens?
Right.
Is it perhaps creams that you're applying? And even then you'll see more of a pattern in certain areas depending on how you apply it. Certain cosmetics that you're using. Certainly if you have pruritus, like you're really, really itchy and you're going at it in certain areas, that might show more marked darkening, in which case we really have to look at what's causing that itching. Is it the psoriasis? Is it flaring up? You mentioned eczema. What is causing that flare up? Is it another trigger, again, an allergen
or
that you might be exposed to, or a secondary infection? She's seeing a lot of them on the rise because of COVID. A lot of the stuff we're using, we're seeing a lot of barrier defect. And when you have barrier defect, very common in eczema for sure, you get cracks in the skin, and that becomes really welcoming to opportunistic microbes. And so you can have secondary infection that causes that crazy, crazy itching, right? So then the target would be, okay, let's get that secondary infection under control. Let's get that inflammation down. We stop the itching. Now we stop the inflammation, and then we give time for the skin to normalize its tone again. So you really go
Pretty
back
good.
to...
Pretty good. Pretty good.
You really go back to the source. But please drop us a DM if you'd like more information. We might be able to refer you to a doctor if you're not already managed by one in your state, or drop us an email from our website, and we'll help as best we can. Okay, I think we're good. This is nice. A shout out to you, Sorphil. Doctora is a rare gem and champion of psoriasis patients. That she is, I can attest. She's one of the few who treats psoriasis patients holistically, from treatment to lifestyle. Very generous with her time, exploring with patients their probable triggers, including referring them to therapists, including EMDR specialists. So she's had patients who have either become resistant to biologicals or really can't afford them, who are basically staying clear on therapy, primarily, as well as allergen avoidance and all these things, of course. But yeah, I would agree. And for those, again, looking for help, psoriasis organizations, they do abound now. The International Federation of Psoriasis Associations has several that are local in each country that you can look up.
Yeah.
So,
I'm part of the Psoriasis Global Alliance.
There you go.
That's a combination of the Manchester group and the international IFC, the support group that is the head group for it, and 2 or 3 others. I'm really sorry, but they're actually trying to go all over the world now to make a psoriasis global atlas, and that's why I'm quite busy now preparing for my report to them as the regional head.
So I will let her go, but before I do, what can you give me the generic name of some of the biologicals? There's adalimumab,
infliximab, and Remicade.
What is the one in the States? I see all the commercials for it. It's also used for rheumatoid arthritis. Humira,
Etanercept,
Etanercept,
Humira, and then the more focused ones would be the IL-17, IL-12, 23. They are the targets. Those interleukins that I just mentioned.
Interleukins, that's right.
Yeah.
So
and
again,
then there are so many new coming up now. Here in Manila, the newest we have is ikizumab, and but there are, oh my gosh, there are now biologics that can achieve after about 12 weeks to as much as 90% passing.
they're really
clearance.
rather
Fantastic.
phenomenal, guys. But it is a holistic thing. So I will summarize, but I will let you go because I know you have this.
I love you all. You take
database.
care, stay home, put a mask on and distance, okay?
Definitely.
Bye-bye.
Thanks, Mom.
Thank you. Hold on.
Okay, you got it. There you go. Here's your juice.
Oh, my book. Show that to me.
Okay, actually, this is sort of relevant to our previous discussion on hyperpigmentation. This is another one of her books. It's actually a textbook for dermatologists primarily, but it does deal a lot with hyperpigmentations. And some of her studies here on visible light indoors are still this was written in the 90s, and they're still the only studies, or the go-to studies, the standards for visible light protection and layering. And the other one that we talk about is her RX Coconuts, which is about oils you need to have in your body. But I will summarize stuff. But in a nutshell, psoriasis before, I think, was extremely feared because, back in the day when we were more ignorant about it, people thought it was contagious. It might look like leprosy. It really isn't. And I think a lot of people used to be afraid of it because it seemed so hopeless. And it just is no longer the case now. Repeating, the International Federation of Psoriasis Associations, SORFIL in the Philippines, there are psoriasis organizations in your country for sure. So look for them because they offer phenomenal support. Again, thanks to work by advocates like Joseph de Guzman. They really address so much, from helping you get a job to helping you get disability cards where you live so that you can get help for medication and other support, helping you with health insurance claims, getting financial aid from the companies that make these biologicals. There's a lot that's going on that these organizations can help you with, support groups and therapy and whatnot. It is an auto-inflammatory condition, so it is never treated as just a skin issue, right? Which honestly, I think we're getting into an age, thankfully, where most dermatologists really agree that there's nothing that's just skin. And we at VMV certainly have always said it's never just what you put on your skin. It's how are you living? If you look at our questionnaire, if you have a very complex condition and we give you a questionnaire, you'll see a lot of the questions have to do with what are your hobbies? What is your job? And it's not a marketing question. It's actually to figure out, do you use like headgear? Are you wearing eyeglasses or goggles if you're experiencing lesions in this area? We'll ask you about your diet, nutrition, sleep habits, etc., and talk about inflammation and the importance of getting those things managed in your life. Certainly for psoriasis, some of the great things that you'll get from a really investigative doctor would be things like a biopsy, possibly a culture for sensitivity, a smear for culture and sensitivity test to figure out if there are other organisms there at play. A patch test for sure can be incredibly life-changing for eczema, for psoriasis, for so many skin conditions, and then lifestyle and diet and mental health and possibly biologicals, right? So there, at VMV, again, what we would normally recommend is extremely gentle hair and body care, like Cool and Clean Mom and Baby Wash and our Essence Conditioner. This is actually my personal stock, so it's a little bit beaten up. And then the Red Better Cleansing Cream, or any of our cleansing creams, but this is, me personally, I like this for psoriasis because it has anti-inflammatories, anti-cathelicidins, and it's allergen-free. And then a daily moisturizer that is allergen-free. So again, get a patch test to find out what your allergens are, but these are without all 109 of all top published contact allergens as of the moment. That is the Mommy Coddling All Over Lotion or the Essence Hand and Body Soother. And then follow with coconut oil. So oils well. Do It oil is virgin coconut oil with monolaurin, which is also an anti-inflammatory, added to it, or our Know It oil, pure, organic, clinically published virgin coconut oil. And if you are prescribed a steroid, take it. But please do not overtake it, meaning if you're prescribed it for 2 weeks, that's what you take it for. You don't take it for the 4 weeks and the 2 years, and you don't use it like a daily cream. It is dangerous, people. We have a live stream about that from, I think, 2 weeks ago, so check it out. But there are many, 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 many real risks. So if you have a subtle flare that's sort of starting, Boo Boo Balm might be able to get it. It tends to do so very well. If you have something that also has redness or itching, the Red Better Calm the Heck Down Balm is a skin saver for sure. And I'd mentioned earlier that pure monolaurin pellets are a common thing my mom tends to prescribe, as well as, interestingly enough, melatonin. And again, this is not a product that we make. This is just the personal one that I buy. But I'm not particularly loyal to any brand. I just try to look for quick dissolve or sublingual melatonin because it gets to your system faster. So you can shop most of these things, obviously not the stuff we don't make, in the USA at vmvhypoallergenics.com. We do have an ongoing special now on our virgin coconut oil, so check that out. And in the Philippines at vmvhypoallergenics.ph, where our ongoing special is this pouch with 4 skin calming products in there. It has the Essence Clark Wash, Essence Conditioner, Red Better Cleanser, and Oils Well Mini. So why did I count like that? I think that's 4 products. That's in the Philippines. And in the Philippines and the United States, we are offering 10% off our makeup removers. So, you can wipe off some of the stress. They're excellent. I personally love them. I use the oil one. We have an oil-free one. In the Philippines, again, we have closed the chronic spontaneous urticaria study. We have enough subjects, but there is another excellent study for hidradenitis suppurativa. And if you would like a teleconsultation with my mother or any doctor or nutritionist that we work with, drop us a DM. If you have more questions about psoriasis or eczema or anything else, feel free to keep them coming here on YouTube and Facebook or on Instagram, Twitter even. You can find us, and certainly on our websites. And if you have had a patch test, you can, anywhere in the world, email us or contact us on our website and let us know your patch test results, and we can customize recommendations for you based on your particular allergens and possible cross-reactants. It's a free service that we do. And so there, join us every Wednesday morning in the Philippines, Tuesday evening in the United States, 9 p.m. Eastern Standard Time. Please don't forget to subscribe and like all of our social media platforms, and let us know in the comments what else you'd like us to talk about. Maybe you want us to do another session on psoriasis. It's a thing, or eczema or contact dermatitis, and we'll happily do that. And if you would like to chat with me, I am on Instagram at Laura@VMV. So it's LauraATVMV. And I don't tend to do direct messages, but I do love to chat. So find me, and we can talk about skin and other things. Otherwise, folks, that's it for this week's Skinsights. I'm Laura, again, of VMV Hypoallergenics, and thank you so very, very much to all y'all out there with psoriasis, eczema, and inflammatory skin conditions. We feel you, we live for you, we want to do right by you, so take care. I know it's a challenge sometimes with the pandemic and all the stress, but we gotcha. So hang in there, and I'll see you next week. Bye-bye.